Hello everyone, I am Mohammad Alsharhan, a nutrition support pharmacist and residency program director at King Faisal Specialist Hospital and Research Center in Saudi Arabia. It is my pleasure to be with ASPEN to present my residency research entitled Efficacy of Thiamine, Pyridoxine and Folic acid supplementation in critically ill patients requiring continuous renal replacement therapy. That research I did with my preceptors when I practiced a nutrition support residency at Emory University Hospital. Authors of this study have no disclosures. It is known that trace elements and vitamins are important micronutrients for physiologic, immunologic, and antioxidant functions. Stress factors associated with the critically ill patients, especially those who require CRRT, are at higher risk for micronutrient deficiencies. However, the standard supplementation of trace elements and vitamins may not be adequate to meet nutritional needs in critical conditions. Our group previously published a retrospective study on micronutrient alteration during CRRT. This study at Emory University Hospital over a 3-year period showed high rate of deficiency of thiamine, pyridoxine, and folate, along with other micronutrients. The incidence of micronutrient deficiencies in critically ill patients who require CRRT, according to that study, may be higher than previously reported studies. In light of the study results, Emory University Hospital implemented an empiric standardized micronutrient supplementation in all the critically ill patients requiring CRRT. This supplementation protocol consists of thiamine 100 mg, pyridoxine 200 mg, and folic acid 1 mg to be given intravenously every two days at the onset of CRRT and regardless of the feeding status. The primary objective of our research was to evaluate the efficacy of the supplementation protocol on reducing deficiencies of these micronutrients in critically ill patients requiring CRRT as compared to our previously published study. We also identified other nutrient deficiencies in critically ill patients requiring CRRT. Our study was a retrospective chart review from the period of March 2014 through August 2017. We included patients who required CRRT and on the standardized protocol of thiamine, pyridoxine, and folic acid. Those patients also must have at least one micronutrient level obtained during the period of CRRT. We excluded patients who required CRRT for less than 48 hours. We initially screened 770 patients, and we end up with 259 patients who met the inclusion criteria and included in our study. In this slide, we see the comparison in demographics between the previous published paper and our current study. If you notice the difference in number of patients included in both studies, and one thing that we need to mention that the previous published paper was mostly on patients who received parenteral nutrition during CRRT period. However, in our publication, we looked at all patients who received CRRT regardless of their nutrition intervention. In this slide, we see more details of a primary ICU diagnosis and the past medical or surgical histories of patients included in our study. In this table, we see the results of our primary objective to evaluate the efficacy of our standardized micronutrient supplementation. When compared to our previous publication, our intervention showed a statistical significant differences in reducing the incidence of thiamine and pyridoxine deficiencies. Folic acid deficiency was less numerically, however, did not show a statistical significant difference. We also looked at other micronutrient levels during CRRT. As you can see here in this slide, vitamin C, copper, and zinc deficiencies were consistent in patients included in both studies. We also evaluated additional micronutrients that were not included in our previous publication. Selenium, vitamin D, and carnitine levels were low in some of our included patients. Our sample size, 259 patients, is the largest compared with all other studies investigating micronutrient deficiencies during CRRT. Consistent baseline micronutrient levels and lab draw intervals are lacking due to our retrospective analysis of all patients ordered for CRRT. In addition to the effect of the CRRT itself on micronutrient levels, deficiencies may be also attributed to past GI surgeries, inflammation, and other comorbidities. In conclusion, our current supplementation protocol during CRRT significantly reduced the incidence of patients with thiamine and pyridoxine deficiencies. Other micronutrient deficiencies, like vitamin C and copper, remain high. In light of our data, a plan to modify the current hospital CRRT micronutrient supplementation protocol to include vitamin C and copper. A rigorous prospective study with well-defined serial time points for micronutrient assessment is needed in ICU patients requiring CRRT. These are the references for my presentation. It's my pleasure to present at ASPEN. Thank you very much.